Let's see. It says it's live.
All right. Good evening, guys. Thank you for joining me. I'm happy to be back with you. It's been a while since we've talked, and I've advertised on Facebook. I've got several very special guests here with me tonight to talk about post-acute sequela of COVID-19, or more colloquial known as long hauler syndrome. I've got Dr. Bruce Patterson, Dr. Yogendra, and then my friend from East Carolina University, Jenny Hobbs, who worked at the East Carolinian together. And so we are going to talk a little bit just in brief about some COVID update things that have been going on in the past few weeks. And then we'll dive headfirst into PASC. So one of the first things I want to talk about was just in general updates. The United States, comparatively to the rest of the world, is actually doing very well. While the caseload in the United States has relatively plateaued, we're not seeing the massive increase in COVID cases like we're seeing internationally. If you look at India, Brazil, the Philippines, Germany, Poland, Argentina, Iran, the Ukraine, Colombia, Peru, Canada, Iraq, Chile, the Netherlands, all of these countries are having hyperbolic increases in their COVID rates if you look at the graphs of those countries. So we need to be thankful that at least in the United States, while we're not out of the woods yet as the variants are here, we're certainly doing much better than these other countries internationally. An update on some of the other vaccines. The Chinese vaccines, we've learned, now have significantly more poor efficacy than was initially advertised. About 50% against the Brazilian variant as far as mild to moderate cases, and about 80% against severe cases. That goes for Sinovac, Sinopharm, CanSino, all of those vaccines, which may contribute to the fact that some of these countries are having more issues dealing with COVID-19, even though their vaccination rates are starting to increase because the Chinese vaccines aren't as efficacious as we had hoped. Some of the bigger news you've probably heard more here stateside. Pfizer has asked for an emergency use authorization for its mRNA vaccine for 12 to 15-year-olds, citing a study of 2,260 participants, ages 12 to 15. Those groups are split essentially 1-to-1 placebo to vaccine, and there were 18 cases of COVID-19 in the placebo group and none in the vaccine group, showing a 100% efficacy of the Pfizer vaccine in young children. So they are asking the FDA to provide an emergency use authorization for that demographic. Moderna has published data in the New England Journal of Medicine showing antibody protection for its vaccine extending out at least 6 months, although the antibody levels were shown to be lower in participants who are over 55 years old, especially those that were 71 years old compared to those between the ages of 18 and 55. A small study in Israel compared 400 people who contracted COVID-19 who were vaccinated versus those who were unvaccinated, and found that the rate of the South Africa variant among those who were vaccinated was 5.4% among the positive cases and 0.7% in those who were unvaccinated, suggesting there is some viral escape from the Pfizer vaccine in regard to basically compared to what Pfizer has said prior. I've long said that Pfizer has been on the record as saying that they didn't think that their vaccine would be affected by the South Africa variant. This study shows cracks in that. The antibody data shows some cracks in that. So we'll see how this develops. This is a very small study overall. So that's kind of it for major updates with COVID and vaccines. And so we'll turn our attention here to post-acute sequela of COVID-19. So worldwide, there have been over 136 million confirmed cases of COVID-19. Estimates show that 10 to 30% of people who are afflicted with COVID-19 will go on to have symptoms lasting longer than 12 weeks, termed either long hauler syndrome or post-acute sequela of COVID-19, as it has been more formally called at this point. Using the most conservative numbers, that's 13.6 million people who are currently affected, and up to as many as 40 to 50 million people. The effects of this include chronic fatigue, headaches, shortness of breath, loss of taste and smell, muscle weakness, brain fog, and other neuropsychiatric and cognitive dysfunction, sleep disorders, anxiety, and depression. Most importantly, there is a study that came out of Lancet Psychiatry that looked at 236,000 patients who had been diagnosed with COVID-19 and found that 34% of these patients were diagnosed with a neuropsychiatric disorder following their illness. For 14% of these patients, this was a new diagnosis. Mood and anxiety disorders were the most common, followed by substance abuse and insomnia. Neurologic complications were more rare than psychiatric complications at 2.1%. But I think the big one to note here that was that 0.7% of patients were diagnosed with dementia. Actually, I have a friend who has one of his friends was diagnosed with a pseudodementia, actually a relatively young person. And we found that the risk of neuropsychiatric complications was increased in those who were severely ill, especially those who are in the ICU. So this time, I'm going to ask my friend Jenny to take over. And she was diagnosed with COVID-19. And I want to let her tell you about her experience, how she was diagnosed, and I guess her experience with the medical system. And hopefully her story can help others out there who are listening who want to better understand this disease. And the biggest thing I want people to understand is a lot of people who talk about COVID-19, when you have people who are, I guess, naysayers, they say, well, the death rate is, only 1% to 2%. Well, it's not a zero-sum game. There's going to be significant complications, as we've talked about, from PASC, including patients like I saw this week at one of the hospitals I work. She was she's under 65, and she'd had COVID a couple of months ago, and she was in rehab for a couple of weeks afterward regaining her strength, and she is now afflicted with severe lung scarring, pulmonary fibrosis, and is now oxygen independent. And so even though, yes, she didn't die, her life is forever changed. I mean, I've seen several patients with pulmonary fibrosis post-COVID who are oxygen dependent, and their lives are changed. And this is going to significantly affect the workforce. You're going to think about a long-term disability in these patients, people who can't come back to work, people who can't provide for their families any longer. So when people say, well, the death rate is relatively low, which it's really not compared to other diseases such as the flu and more common illnesses, it's not a zero-sum game of, did you die? There's a lot more to it. So with all that being said, I'm going to turn it over to Jenny and let her share her story. Then I'm going to let Dr. Patterson and Dr. Yo introduce themselves, and they will talk about what the great work they're doing with PASC, talk about the science of the CCR-5 receptor and how targeting that receptor is a novel approach that can help patients who are not only afflicted with PASC, but can also help patients who are infected with COVID-19. So that being said, I'll turn it over to Jenny. I think you're on mute, Jenny. There we go.
There we go. He fixed it. Okay. Hi, my name's Jenny, or Jennifer, whichever one. John knows me as Jenny because we went to college together about 1 billion years ago. I am a preschool teacher. I live in Oregon now, and I was diagnosed on November 15th. And have had symptoms for the last 146 days, I think it is. I have a plethora of notes that I had to take because my brain fog is awful, which is terrible. And for everybody out there who has to deal with it, it's a real thing. Like, I was doing laundry and I forgot to close the washing machine, so it never got done. And it's little things like that. It's super forgetful. I drop everything in my classroom. If I drop something, I just yell gravity. And then I've taught my kids about gravity. It just falls to the floor and they come pick it up for me. But I'm on a COVID survivor site on Facebook that I alerted John to a while ago. And it's people over and over asking the same questions. The hair loss, that is the biggest visual part for me. I cut 12 inches off halfway through February because I was losing handfuls of hair at a time. I go from hot to cold. I'm tired all the time. I have a headache almost constantly. One of the moms of one of my kiddos in my class, I sent her a message and I was like, hey, I'm going on to do this thing. And she said that she's had 4 migraines a week since she was diagnosed with COVID, and they finally ordered an MRI. I was referred to the pain clinic on March 9th and just got a call back this week, and they don't answer phone calls on Fridays. So I didn't get to schedule that. Because I was told to take Tylenol and ibuprofen, just like everybody else has. And then when I requested lab work and had it done, my doctor was like, "Ooh, you got to lay off the Tylenol. You're taking it a lot, huh?" Like, yep, every day, because that's the only options they've pretty much given, which isn't anybody's fault, but it just really sucks. I have trouble with dexterity. I can't hold on to things like I used to. That also causes me to drop things. I'm dizzy if I get up too fast, if I bend down too fast, if I move too fast. I still have a little bit of the muted taste and the smell. It's gotten a little bit better as time has gone on. But I would say I had total loss of smell and taste when I was diagnosed. And I celebrated Thanksgiving only being able to taste garlic salt, because that was the one taste that had come back. Was like, it was so weird. Everything tasted like garlic salt, but at least I could taste something. It looked really good. My mom made it and dropped it off on my porch for me. I was off of work for a month. I went to the doctor and she cleared me to go back to work. I had a week of work before 2-week vacation for Christmas break or winter break. And so I only had 40 hours to work before I got 2 weeks off again. So that was pretty much the only reason she cleared me. But my return to work letter from the health department said I could go back after I quarantined for the 14 days. I was not in any sort of position to go back to work. I joke that COVID land is a lawless land where you just sleep and don't really eat anything, and you just sleep a lot and you wake up in the middle of the night, and it's just weird. I still take about 1 to 2 naps a week after work. I'm back to working 40 hours a week. I teach preschool in class. I've had my kids since October, and I have 20 of them. And so when I first started going back to work at the beginning of January, I took a massage table into like the art supply room, so that I could lay down and rest my body on my lunch breaks, because just being up and being active, I couldn't make it through the day. But I still needed to be at work, and I still need to support my kids and support my job. And it doesn't, it's not the same when I'm not there. So, little kids, they need consistency, and I am their consistency. So it's very, very important for me to continue to do my job, but I had to come up with accommodations for myself. I drink about the big thing of Gatorade at work every day. When I don't feel good. I take a huge amount of like anti-inflammatory supplements. Pretty much anything that anybody suggests, I give it a shot. At this point, it's like cinnamon and garlic and ginger, turmeric, black pepper. I mean, the list goes on and on. I recently traveled to Hawaii for spring break. And that was amazing. I've had both of my Pfizer vaccines and long COVID and COVID. And I was super scared I wasn't going to test negative, because they test you before you go and then once you get there. So I had the letter from the health department just in case that said, yes, I had COVID, but I was okay to go back to work. And recently, like I've had my ex-husband's cousin just died from complications of COVID. I have family in North Carolina who doesn't believe that COVID is a real thing, even though that I am constantly dealing with it. Recently went to vacation in Florida because they didn't have mask mandates like they do other places. And it's soul crushing. It is soul crushing when you live somewhere that does believe in it and people don't around you. But I can't even imagine. I was telling John the other day that I just cannot imagine living in North Carolina still, where people just are so against it. I think it's probably because they don't understand it. That's what I would hope for, at least. But it's life-changing. First thing I do when I talk to parents or friends that I know had COVID was check in with them. My sister had COVID and she jokes that she had Corona Light and I had Corona Extra. Because, it's our life. It's how you have to deal with it. And you have to find some sort of humor in it. But I go back and forth between like being dizzy or not being able to sleep. I take like ibuprofen PM at night to help me fall asleep. Once I'm asleep, I'm okay. But I just toss and turn, hot and cold. My temperature doesn't regulate really well. And then the joint and muscle pain and the headaches. Those are the things that are so extremely constant. It just hurts. My body just hurts. I'm really lucky to have assistants who are picking up where I can't. My leg goes numb. I've read studies where your skull is holding your brain in. And so if your brain is inflamed, it has nowhere to go. So that causes pressure and causes the headaches. And I'm like, okay, well, that makes sense. At least there's that. So, but the internet is so vast and there's so many people who don't have any answers and who really feel like they're alone in this. And that's the scary part.
Hey, so Jenny, I have one question before we'll get to Dr. Yo and Dr. Patterson. So I'm a member of the large international Facebook group for emergency medicine physicians. There's over 20,000 of us on the group. And I feel like I see routinely, like every 1 to 2 weeks, one of the physicians will go on there and will post something. It's gotten less, but it was literally every week to 2 weeks, some emergency physician would go in and complain that they saw a patient who came in complaining of the symptoms like you had, and they said, somebody had, fibromyalgia, or, just felt like, these are psychosomatic symptoms. They aren't real. And, I'm always speaking up saying, hey, this is a very legitimate illness. I mean, I've been reading about this. Dr. Yo, when I came on that, we kind of came onto this by reading about, some of the drugs are used to treat long COVID, or hypothesized to treat long COVID. And, what was your experience like when you talked to a physician or when you sought care for your long COVID or PASC symptoms? What was your experience with the healthcare system?
So very limited. I sent a message over it. My chart is what we use here. It's the phone app or online, whatever, so that you can send the messages and get your results and all of those things. The online medical part with your doctor. I popped a fever, spiked it. It was like 101.3, which is absolutely not normal for me. So I knew that something was wrong. I had 0 symptoms until that Sunday. And I was super dizzy and I was just a mess. I got the fever. I called my boss and I sent the message to the doctor. The doctor put in a referral for me to go get the COVID test through the hospital. It took a week for me to get the results back. So I didn't get notified until Friday that I was positive, which my employer had said if I had gotten a letter from my doctor saying that, my symptoms were clearing up or whatever, that I could have gone back to work, which is terrifying. And I didn't see my doctor. I called, I have the little pulse ox finger thing, and my oxygen was down to 92, I think. And I called the doctor, and she says, well, we're super limited on what we can do and spaces that we have. So if it drops below 90 on a consistent basis, then come to the emergency room. Call first and tell them that you have tested positive for COVID, and then they will let you know what needs to happen. But call the emergency room first so they know. And it never consistently went down. And so I never went to the hospital. I never had any of the steroids. I never had lung treatments. I asked my doctor at one point if, like for an inhaler, and she was like, well, if your cough isn't really, going on a lot, then, we'll hold off on that. Okay. So,
and then when you went back and you're COVID, and then you start having all these other symptoms, when you talk to your provider, did you find that they were aware of the PASC of these long COVID symptoms, or did you find that was a struggle?
It's a struggle. I showed up at the doctor's office and my hair is super short. I had cut it 2 weeks before that, and the nurse was like, oh my God, I love your haircut. And I was like, thanks. It's because I have long COVID and I'm a long hauler and my hair was falling out. And so she goes in, she checks me in and does all of that. And she tells the doctor that I'm there. And she asked the doctor, like, is hair loss a symptom of long COVID? And my doctor says, everything is a symptom of long COVID. And so it's like, she acknowledges that what I'm going through is part of this, but she also acknowledges that she doesn't know what to do about it either. And like the Tylenol thing, she told me not to take it anymore. And so that's when she referred me to the pain clinic, so they at least can follow me a little closer. But it's been a month that I've just been taking ibuprofen because that's the only option that I have.
Gotcha. But yeah, so it's certainly a very difficult story to hear. Looking in the comments over here, I mean, Jenny, there's people talking about this sounds like there's literally tens of comments here saying this sounds like my story from people. I mean, many states I've seen. I saw a comment from France. People telling me this sounds exactly like my story. And thankfully, we've got folks who do understand PASC, like Dr. Yogendra and Dr. Patterson, who are really doing some groundbreaking work on this illness. And I want to give them the floor, if that's okay. You to talk about, essentially, hey, you guys, tell us of your experience being the experts on this, and what are you seeing, and tell us about the groundbreaking work that you guys are doing that can help people like my friend Jenny.
Hang on. Bruce,
go ahead.
Here you go. Okay, cool.
Oh, I was muted. Okay. I'll give a little bit of a historical perspective on it, and then Ram can talk about the program that we developed, and then we can talk about what we think is some of the causes, and certainly some of the treatments that we've been using successfully. It was probably in the beginning of last summer, and Ram can jump in if my memory doesn't serve me well. But we were in the midst of a number of different clinical trials for different therapies for active COVID. And what really struck me at day 28 or even day 40, or even some later samples that we had, and eventually one was day 87, was that people were getting better, their lives were being saved, they were getting out of the hospital, but by no stretch of the imagination was their immune system normal. I mean, they had sky high cytokines. You talk about joint pain and muscle pain. Interleukin 6, interleukin 8 are classic cytokines that cause muscle and joint pain. And so they were still elevated by the time they left the hospital, or they were still elevated in patients with mild to moderate disease. The bottom line is people survived, but they were not normal. And then we published a paper in November where we followed an individual for close to 3 months and continued to find active COVID and COVID RNA in this individual. And, the interesting thing was this individual still had decreased CD8 percentages. So CD8 and CD4 T cells are part of your immune response against viruses. And we know from HIV that the CD4 counts are very, very low. Well, in our early history in February and March 2020, the CD8 counts were in the single digits when they're supposed to be 30. I mean, I started my research career in HIV, and it was HIV in a different cell type. I mean, it was the immune system was highly compromised because of the low CD8 percentages. And so then, once we started studying long haulers and long COVID, 25% of the patients that we've seen still have low CD8 percentages, which is just not normal. And again, our program is now up to 4,500 patients that have registered. We're testing them as quickly as we possibly can. We've treated well over 100. What we're seeing is just an incredible immune response. And, if you can you show the couple of slides that I sent? This is actually there's one slide that has very, very new data on here. If we can pull that up. But what we did is when we started studying these patients who had symptoms months after having active COVID, we then developed an algorithm using machine learning and artificial intelligence to say, what's the difference between somebody who has long COVID symptoms and somebody who has active COVID or is normal? And the fact is, it's a completely different entity immunologically. So when people say, "Oh, we'll just use COVID drugs on long haulers," it's absurd because it's completely different immunologically. And we did the bioinformatics to show that paper's being peer reviewed right now. And then the fact is, you have to think about it differently. You have to treat it differently. Some of the common denominators were that 71% of patients with long COVID still had elevated RANTES, which is the protein that binds to CCR5 on immune cells and basically attracts, almost like pheromones in insects, it attracts immune cells to sites of inflammation. And if you block that, then you don't get the localized inflammation. And this can happen in any of the organs: kidney, liver, brain, heart, lung. And so I think that blocking this key component of the immune response, I think, was extremely important in active COVID using CCR5 antagonists. And then now as a part of our armamentarium in long COVID, we've been using CCR5 antagonists since October, treating long COVID. And, the fact is, now we just discovered in the last month another reason why the CCR5 antagonists are working in long COVID, and we're anxious to get that published. But while we're waiting to get the slides pulled up, Ram, why don't you discuss the program that we jointly started, and how well it's been going, and all the elements of getting these people feeling better.
Yes, thanks, Bruce. Do you think you mute? Okay, perfect. Because we always get echo from your speakers. So yeah, the program, it's interesting. One of the things that we wanted to do, I always say there's a disconnect between the research and the clinical world. And what the really interesting thing that we've been able to do was really take some of the groundbreaking research that Dr. Patterson and IntelDX have been doing and making clinically actionable plans. I think it's great. You might have a great finding or a paper or finding in general, but someone like your friend Jenny over here and the countless of those long haulers, they don't really care about publications and the researchers all patting ourselves on the back if we cannot make clinically actionable plans and make your lives better. Like I said, the research is great and fun and exciting, but that's just the nerdy side of things. We're in the business of making people feel better, getting on with their lives. And what we've done is we've developed a program. It's on covidlonghaulers.com, where patients get tested through a CLIA validated lab. Dr. Patterson's kits have been validated through innovative bioanalysis right now that are doing all the testing. There will be some other labs that will be coming online pretty soon. And once the patients register, they get their lab results. It's the 14-panel in-cell-kind test. They then are able to interface with our clinical team, myself, Dr. Patterson, and Dr. Parikh, who's another immunologist on our team, to do lab interpretation, treatment recommendations based on the research that we're constantly, almost on a daily basis, refining those algorithms and the treatment protocols as we're getting more data and getting more understanding, and then working with your primary care doctors to really start treatment. And the thing is, I know, we've been, Dr. Patterson and I, we've been, we're way past the acknowledging the long hauler. We acknowledge long COVID, long haulers, whatever the terminology we want to use, last June. So we are about 10 months, right, Bruce? 9, 10 months now. So whenever patients come in, we get these emails, we get these giant books. They're writing all these symptoms and go, you don't have to. We get it. We understand. You don't have to convince us. This is why we're here, because we were convinced 9, 10 months ago. But what we've done then is with taking what Dr. Patterson has done in the lab, is to have a medical and scientific justification and reasoning for why we're doing what we're doing. We're not randomly throwing medications against the wall hoping it sticks. We're not trying the CCR-5 inhibitors. We're not trying the ivermectins and the Luvox and everything else and just saying, we don't really know. We have a deep understanding of why, and we can then go to the medical community, the scientific community, and even the NIH and some of our government officials, and say, this is the scientific and medical reason we're doing what we're doing. And these are the clinical improvements from the patients using the long hauler index score that was in the first paper, to now give justification. And by doing that, you get buy-in from the medical community. And again, it's been a long process, a lot of hard work that went into it, but we're finally getting there. We're starting to see some fruits of the work we put in. We've also built a network of physicians, and this is the most exciting thing, because someone like Jenny, for example, we can test you. That's great. But if we can't use that data to get started on treatment, what's the point having these really cool cytokine elevations and T cells and all this other stuff? And part of the program we've developed is a holistic, comprehensive program. The patients get tested, they get the consultation, and they start treatment. And if your physician did not, or for whatever reasons, we're not comfortable treating you, they just are still resistant that long haulers or long COVID exist, well, we created a network. That network literally on a daily basis is getting bigger and bigger. We have doctors, nurse practitioners, PAs, researchers from all over the world that are reaching out to me and Dr. Patterson saying, we want to be part of this. And we're doing these closed door physician webinars, medical personnel webinars. So Dr. Patterson is sharing all the research, from the lab, and also clinically what we're seeing with some of the medications. And it's just been really, really exciting. And the website is www.covidlonghaulers.com.
That's the first I've heard of the website. So I'm on my computer and I opened it up. because I can do that and do both at the same time. And I'm super excited about it. So I will be sharing that in my groups today. So thank you. Thank you. Thank you. Thank you. Any more information that we can get? I've got the comments open as well. And I mean, people are going through and saying that their doctors don't believe them. And that one of them said that they need a psych appointment because they're obsessive about the long COVID. And it's so many of us that just feel so unheard and crazy. And the longer that we have to deal with this, the crazier we feel, because people aren't acknowledging this, and there's a lot of people who don't, but there's a lot of physicians and a lot of long haulers who are just like banging their heads on the wall and crying themselves to sleep because we have no idea what else to do. So thank you guys for all of the work that you do and all of the research that you have been working on, because it is valuable. You guys are all very valuable, and I appreciate it so much that I get to be on here with you guys.
And we will definitely make sure I will post a link on my page to covidlonghaulers.com for Dr. Patterson, Dr. Yo, and my friend Bubba Rosenbaum is actually behind the scenes here producing for us tonight, so I can focus on the content and keeping the conversation going. And so he is getting the slides up for us, so Dr. Patterson can talk about the science of CCR-5. Admittedly, it's a very difficult topic. We are actually talking before we came on about this is stuff that you don't really learn a ton about in medical school. The science here is, like I've said, it's groundbreaking, it's pioneering, and Dr. Patterson is the world's expert. So there's nobody better to hear it from than Dr. Patterson. So we've got his slides up. So I will let Dr. Patterson take the floor again and tell us all about CCR-5 and more about what they're doing. Need to unmute Bruce.
There we go. If we go to the first slide, I'll just reiterate some of the points that Jenny's made and Dr. Bream has made, is that there are just so many different symptoms, and this is from our first paper, and really didn't probably capture all the symptoms out there, but it certainly captured the major symptoms. Is there a way to go to the next slide? Okay.
John, is there a way to get the slides in a presentation format?
Yeah, I'm trying to talk with Bubba right now about trying to get the next slide pulled up. I just sent him a text like next slide.
Yeah, John, bear with me one moment. The next slide was showing on my screen, so I don't know why it's not showing for you guys.
Okay. And Dr. Patterson, were you saying trying to get in a different format?
This should work. I can. I wonder if I could. I don't know if I can share this myself, but the bottom line is I'll talk through it. I mean, obviously there's this huge spectrum of symptoms in long COVID, and one of the commonalities, obviously, with some of these symptoms is the fact that these symptoms are caused. Well, there we go. Here are the symptoms. From left to right. I mean, fatigue is over 20% of all long haulers. Brain fog, over 20%. Shortness of breath, neuropathy, and when we started looking at long haulers last summer, in addition to the algorithm that we were developing for the different inflammatory markers, The other thing we wanted to do is also say what symptoms relate to which cytokines or which inflammatory markers, so that we knew what to target with drugs. And I think that's the next big project we're working on. I actually have the first data to show you as one of the later slides. And the other part of this was then to show which drugs relieve which cytokines or reduce which part of the inflammation, so that you can say, if I have this set of symptoms, because believe me, every single one of those 4,500 patients that we've talked to is completely different in terms of what symptoms they have. Now there's obviously some commonality, but in terms of the complete picture, it's very heterogeneous, which was remarkable that we found what we call a long hauler index, which is on the next slide. If we can can we get the next slide? Yeah. Or maybe the next slide, because it's bigger. Okay, this is a good slide. We have two indices that we developed, one for active COVID called the severity score, which is on the y-axis. And on the x-axis, we have the long hauler score, long hauler index. The one thing that comes out to you immediately is that long haulers who are in yellow are completely different than active COVID who are in red and blue over on the left side. Okay, so immunologically, we'll go back to the next one. Immunologically, they're two completely separate entities. So like I said, there was no reason to believe that COVID therapies would work in long COVID. However, we found some similarities, and obviously one of the similarities was that this protein RANTES, which is elevated in active COVID, was also elevated in long haulers. The thing that makes the big difference between long haulers and active COVID are two cytokines called interleukin-2 and interferon gamma. What's really interesting is interleukin-2 and interferon gamma are two cytokines that are intimately involved in antiviral immune responses, and they're low in active COVID because it's an emerging infection. Our immune system presumably has not seen that virus before and can only at least begin to initiate an innate immune response as opposed to an adaptive immune response. So long COVID actually has an immune response with high IL-2, high interferon gamma that looks very much like a typical antiviral immune response. And beyond having high IL-2 and interferon gamma, long haulers have a plurality of other immune biomarkers that are elevated. They have elevated VEGF, which is made by immune cells and endothelial cells. They have elevated TNF alpha. They have elevated IL-6 still, which can cause muscle and joint pain. So you're starting to see this pattern of immune markers that correlates with a lot of the symptoms. And then, of course, when we think about targeting therapy, we at least have the data of these 14 different cytokines and chemokines, as well as the data on the immune cell subsets in the blood to really target our therapy. What's very interesting in long haulers is they have elevated B cells at times, so about 20% of them, which may reflect an expansion of latently infected Epstein-Barr B cells because they have low CD8, so they can't fight off the viruses that they were infected with prior to having COVID. And they also have an elevation of some monocyte subpopulations, which act as antigen-presenting cells, which I'll go into in more detail in a moment. But next slide. this is what's coming out in a article, I think in about a week, which is when you look at our 14 marker panel, TNF alpha, interleukin 4, interleukin 13, IL-2, et cetera, across the top row, and then you look at the various long hauler symptoms on over on the left-hand side in the left-hand column. What we did is we looked at the levels, and this is in over 300 long haulers. We looked at the levels of these cytokines in patients with the various symptoms. And some very interesting things came out. Number one, as I mentioned, IL-2 is a cytokine that's elevated in every long hauler, and it's part of our long hauler index. Well, interleukin 2 is related to fatigue, chills, brain fog, arthralgias, burning sensations. Just about every symptom you can have is related or is associated with elevations in IL-2, which now when you come from the other direction, we can bring down with drugs like ivermectin, steroids, and I'll get to Maraviroc and Luvoxamine in a minute. And then the other thing that you notice is VEGF over on towards the right-hand side is very much associated with fatigue and is probably the most important immune marker associated with brain fog. And 79% of long COVID patients have elevated VEGF. Now, why is that important? Well, VEGF is vascular endothelial growth factor. We still think there's a lot of inflammation in the blood vessels, causing microclots, as some people have hypothesized. But VEGF may also be a response to damaged endothelium. And so VEGF is a very important marker. Now, like I said, we know what drugs bring down which of these markers. So we can tailor therapy based on this chart to each individual long hauler. And that's what our program is all about, is using precision medicine to determine how to treat. Not, let's try this drug, let's try that drug, or this drug worked in COVID, I think it will work in long haulers. It doesn't work that way. And what's very interesting is that we are able to tailor therapy in these individuals. Next slide. And now here we're getting into an actual patient that we treated with Maraviroc, which is a CCR-5 antagonist. The patient came in, had elevated RANTES or CCL5, 14,000, had elevated VEGF of 39 when normal is 9. After 2 weeks of Maraviroc, CCL5 or RANTES returned to normal at 10,000. VEGF went from 39 to 11, which is in the normal range. This patient felt, I would say, 95% better. And their long hauler index, which is the index we derived with machine learning and artificial intelligence, went from 11.4 to 1.3. So we actually have a non-subjective means to assess whether or not somebody's responding to therapy and link that to improvements in symptoms, which is probably the most important part. And why is that so important? Well, it's incredibly important because, like Jenny said, these symptoms are widespread. There's good days, there's bad days. Trying to assess how somebody is when they appear in a doctor's office over time without some non-subjective way to measure that would be next to impossible from the stories that I've heard. And, again, part of the work that we're doing is now leading not only to effective therapies with combinations of drugs. And I'll tell you, single drugs do not work. I mean, if you talk about ivermectin, 50% of people feel better with it, 50% don't. Steroids, 50% of people feel better with it, 50% don't. Maraviroc, 50% feel better with it, 50% don't. It's been the combinations, and it makes sense. I mean, ivermectin and fluvoxamine have both been shown in vitro to have antiviral activity amongst other immune modulatory activities. So, for instance, fluvoxamine decreases platelet activation. So it may decrease microclots that are causing inflamed blood vessels and brain fog. But I think one of the most important things, which we're right now writing up aggressively, is that we've actually found COVID protein in long haulers, and it's in a cell type that commonly migrates throughout the body, including the brain. And so here's a cell type that's bringing an antigen that's stimulating the immune system to different parts of the body. And you know what's fascinating is there's actually two papers. One paper shows that this cell type easily passes through the blood-brain barrier and could potentially bring COVID protein into the brain to cause localized inflammation there. But what's also interesting is there's two papers that show that this cell type is mobilized by exercise. And I can't tell you how many times we've heard long haulers get worse when they try to exercise. So here's a typical example of a story from a long hauler is they're feeling a little bit better. Their symptoms are waning for a particular week. Then they go back because they're a runner, or they're a gym rat. They go back and they run 2-3 miles. For the next 2 weeks, they can't get out of bed. And we've heard this over and over and over again. The other fascinating thing about this cell type is it expresses CCR-5. So it's going to migrate in response to localized inflammation. And by blocking that cascade, we feel like we can really inhibit these cells from migrating around the body and causing localized inflammation. So on top of bringing down RANTES, which of course, like I said, is attracting all of these immune cells, we really feel that blocking CCR5 is also keeping this particular cell type carrying COVID antigen from getting into regions of the body where it's causing localized inflammation. So we're very excited about that. We're writing, like crazy, and we really feel like the paper should be out in the next week or two. So pretty excited to maybe have found, one of the mechanisms of action of long COVID, because I'll tell you, the mechanism of action of long COVID is very different than the mechanism of active COVID. So that's what we're working on. That, and as Ram said, we're trying to translate this information that we come up with on a day-to-day basis into rational therapeutic strategies, while also encompassing a non-subjective means to monitor improvement, or if certain regimen's not working, we'll know it, and then we'll know what to target, the next time with the next round. So it's very valuable to have those tools. And like I said at the Precision Medicine World Conference, I think at the end of the day, the one thing that is severely lacking in COVID, both active COVID and in long haulers, has been the lack of laboratory data to perform precision medicine. I mean, doing C-reactive CRP, D-dimer, SED rates, these are all, as a pathologist, we used to see those. They're very non-specific. They're elevated sometimes in everything. But coming up with a panel that more directly applies to the abnormalities that we've seen, since the beginning of February 2020 in COVID, has been extremely useful in deploying precision medicine.
Okay, can I just real fast, John? So how do we get it? How do we get those testings? Because I asked my doctor for labs and a chest x-ray before I had my vaccine, just so that I could make sure this was not related to this, when I have labs done next time. And, and it's just a normal run of labs. It's not anything specific, and we don't really know what specifically to ask for. There's, you guys are doing the research, and the physicians that are trying to battle this and figure it out with us don't have a lot of information. And so what is it that we can specifically ask for testing? Is there something like that? You're muted, Bruce. Hang on. There you go.
Absolutely. And that's why we started www.covidlonghaulers.com, back in October, is for exactly those reasons. Number one, it's a resource. Number two, you can register and figure out, either your physician can figure out how to get his patients tested, patients can figure out how to get tested, what does the testing mean? So we have publications there and some of the up-to-date research and presentations that we've done. It's all right there. And that was the whole reason of starting it in the first place, was to provide a resource. Number one, there was three things that we needed to show. Number one, long COVID is real. We've been saying it since summer. Okay. And you know what? It's unbelievable that we're seeing articles coming out in newspapers right now saying, hey, long COVID or PASC is an actual thing. Like Ram said, we were talking about it 8 months ago. But again, it's on the website. We're going to continue to publish like crazy, but the website is a resource. You can register and get tested. You can get consultation in terms of interpretation of the lab results that then could be sent to your physicians. We have a network of physicians nationwide, over 100, that you can be referred to if your physicians aren't as informed about long COVID as others. And like Ram said, we have patient webinars. We have physicians webinars to train them on how to use the laboratory data to make decisions about therapy and what to look for. And most importantly, we have an app now. It's not launched yet, but within I would say a month, we are going to have an app and a watch that measures heart rate, blood pressure, oxygen, heart rate variability, in addition to allowing the individual to log their symptoms on a day-to-day basis and score them, while overlaying the laboratory data and their medications, so that we can look at a comprehensive picture of symptoms, treatments, and lab results. And because otherwise, this disease is so complicated, and long COVID is so complicated, we can chase our tails for the next 3 years, trying this thing and trying something else, with no information. But it's all about data. And like I said, the lab's ready. We're completely live now. The lab's ready to go. The app's coming out in a month. We're there.
So I have a couple of questions, and this is probably just for folks who may want to know. Are you finding that insurance companies pay for these labs, or is it out-of-pocket cost, or do you know about how much that runs, and about how long are you seeing that patients have to be treated before they're showing improvement with the regimens you guys are using?
You know what? Those are great questions, and we're almost identical to one of our patient webinars we had a week or two ago. Number one, this test by Innovative Bioanalysis, they use standard anatomic path codes for reimbursement. They will give you the paperwork to submit to your insurance companies for reimbursement. or it can be cash pay. But for right now, it's cash pay, and then they'll give you the paperwork to submit to insurance companies for reimbursement. We kept the price as low as we possibly could for 14 different biomarkers. I think it's about $360 if I remember correctly. And the bottom line is there's a really good chance that it's going to be reimbursed, and we're working on that as well. We're talking to payer groups and others to get reimbursement more codified. But right now we use standard anatomic pathology CPT codes, so there's no reason why it shouldn't be reimbursed.
That's actually a lot cheaper than I would have thought. I know $360 is not a small amount of money, but in the context of medical testing, that actually sounds pretty realistic.
Plus, for 14 markers, and they get put into the bioinformatics algorithm. So also on the report, there's a long hauler index and a severity score for the physicians in the hospitals like yourself that are using the severity score to say, where is my patient immunologically in this spectrum of COVID disease? So that is reported out as a severity score on the same report.
And John, we did, as Dr. Patterson just mentioned, we did a patient webinar. It's about a 40-minute with Chris and I think Sam from the Innovative Bio, where we went in depth into the whole process in terms of the reimbursement, what those CPT codes are. I can send you a link to that. And on our website too, we have an FAQ page that goes in depth into how the whole, not only the process works on the clinical side, but also the lab work and what needs to be done and the reimbursement. So that's all on the website too.
Awesome. And I've asked Bubba, I want him to put up, there's an infographic I sent him that shows sort of the CCR-5, CCL5 Arantes binding axis. So I want him to, Bubba, if you could put that picture up, because I think it's good for us to talk about this. But I think if you don't have a science background, it's probably very difficult to understand what exactly Dr. Patterson's talking about and how the binding of CCL5 Arantes to CCR5 triggers this immune cascade and why the science behind CCR5 receptor antagonists is solid. And so if you could throw that picture up for just a minute, I think that would help our viewers to really understand what we're talking about. And because I think a lot of people see things better in pictures. So Bubba, if you could put that picture up for me just a minute. And then if Dr. Patterson would indulge me here, he'll maybe run through maybe a little bit of the pathophysiology of this so that people can understand a little better. And hopefully Bubba can get this picture up for me. If not, I guess he'll let me know.
Well, I think the easiest way to think about it is think about honey and bees. Okay, honey is Rantes. Okay, and honey attracts bees. Bees, let's say bees are T cells and macrophages that express CCR5, and basically wherever you put honey, you're going to get bees. So, wherever there's inflammation or tumor cells like cancer, immune cells produce CCL5 or Rantes, which is the honey, and that brings in immune cells to areas of inflammation where they do what they're supposed to be doing. And that's exactly kind of what you see here. Like CCR5 is a receptor in the cell membrane. And it's a difficult molecule to stain for because it's what's called a 7-transmembrane receptor. So it doesn't really sit up like that, like a nice pocket for CCL5. It actually goes through that membrane 7 times and then attracts CCL5. And so from a diagnostic standpoint, from a technical standpoint, it's hard to stain for. There's a lot of antibodies, but there are a lot of them that aren't very good, and that's why it's not easy to make things like receptor occupancy assays where you're trying to show that you can block that CCL5 from binding with drugs. What you really need is a antibody that just stains CCR5 because it's regulated, and then you need another antibody that's blocked by the drug, and you have to use them in combination. And the fact is, CCR5, as you see here on cells, is heavily regulated. Sometimes it's low, sometimes it's high. It's a moving target. So that makes studying CCR5 and the pharmacology of CCR5 antagonists even more difficult because it's a moving target. And we published back in the 90s that CCR5 is regulated by cytokines. We were the first ones to publish that in the context of HIV. But what's remarkable is that COVID is all about cytokines. We all talk about the cytokine storm. Well, the cytokine storm is making CCR5 expression on immune cells go crazy, and it's at very, very high levels. So dosing is a key factor in using CCR5 antagonists. And because it's all over the place, and then when the immune system gets better and when things cool off immunologically, the expression of CCR5 goes down, so that maybe you need less drugs. So it's so critical to have an understanding of how much is being expressed. The other big conundrum about CCR5 and immune cells is there's good immune cells and, quote, bad immune cells, but even the bad immune cells have a role. So, for instance, in cancer or in viral infections, you want T cells, CD8 T cells, CD4 T cells, to migrate to the areas of infection, and they do that, partially through CCR5, which is expressed on memory T cells that remember when you got infected prior. Okay. Now, the immune cells come in and start eliciting their immune response against, like I said, either cancer or virally infected cells. But what would happen if your body just had this continuous immune response and didn't have a way to shut that off? That would be a problem, and that would result in autoimmunity. So your body has a very elegant way of sending in these cells called T regulatory cells, which shut off the heightened immune response against cancer and viral infections. Now, one of the strategies in cancer is to inhibit the influx of T regulatory cells because you don't want the immune system that's fighting off the cancer cells to be shut off. Okay. So again, there's this balance between preventing the T regulatory cells from migrating into a cancer lesion or an organ with viral infection. You want to inhibit those, but you don't want to inhibit the good cells. So it's a very fine balance between the amount of receptor on each of the cell types. So you want to know how much CCR5 is being expressed on these good memory T cells, effector T cells, and how much CCR5 is being expressed on these bad T reg cells, and how much CCR5 is expressed on these macrophages, which can be either good or bad. By using CCR5, you can make the bad macrophages good macrophages that engulf cancer cells or virally infected cells. So it's very, very fine balance between good and bad with CCR5 in either viral infections or cancer. And that's the whole game here. But I think the easiest way to understand CCR5 and CCL5 or Rantes is the honey and the bee analogy, where CCL5, which you see in orange there, or Rantes, is the honey. And then the immune cells that express CCR5 are the bees, and they're going to migrate to where the honey is. So the key is, let's shut down the honey or block the CCR5. And that's what CCR5 antagonists do.
Well, thank you for that. Looking through to see if there's any questions here. A lot of people, I've seen a couple questions when you were talking about the cell type that migrates to the brain. A lot of people are asking what specific cell type were you referring to? And I think there's been a couple of questions I saw that talked about, I think maybe a couple of people were surprised given the controversy surrounding ivermectin. That was one of the drugs you guys are using. And so maybe if you could talk a little bit about both of those.
Our publication will be out and we'll reveal what the cell types are. Needless to say, they express CCR5. And what's very interesting is they don't express ACE2 receptors, so they don't get directly infected. They scavenge. And in the story about ivermectin, fluvoxamine, these are all repurposed drugs. And yes, they are controversial because you'll read one study where it works, one study where it doesn't work. And you know what? I'm the first one to be cautious about throwing something in a flask with virus and that, preventing infection of what we call cell lines or artificial cells that we grow in culture to test out various compounds. I always relate this moment from 1990 when I put colloidal gold in culture with HIV and stopped infection of T cells. And, I thought, the pandemic was over. And then as soon as we put that into patients, it didn't work the same way because obviously human bodies work very differently than actually just showed the regulatory mechanisms. The human body works very different than putting something in a flask with virus and showing that it prevents infection of cells. So, but yes, I agree with you that there are controversial studies out there. And I think the key is looking at it in a very rigorous way to say, is it more likely that this is real or not real? And then, there's these studies like one on ivermectin out of Chile where there were so many flaws in the studies, and that was the one that panned ivermectin. And so, there were so many flaws in the study that it was difficult to assess, whether it worked or it didn't work. It's just a matter of talking to people, for me, talking to people you respect, talking about their data, exchanging our data, and saying, does this make sense? And the fact is, to us, it's worked great and in combination, and it makes sense. Same thing with fluvoxamine. I'm not so sure about its antiviral effects, which have been talked about, but certainly in preventing platelet activation, microemboli, vascular inflammation, I think that in of itself is, and also may have effects on cytokine production at the cellular level. So taken together, that's a rationale for using that. So again, all of these have been vetted very carefully by us in conversation with others. And, like I said, real world experience has shown that they're working. And that's what really matters to us.
Fantastic. Well, guys, I know you guys are very busy, and so I appreciate you all coming on to have this conversation. This has been very, very helpful. Couple other some questions that came up. Is there why are middle-aged women who have had a mild to moderate COVID the most vulnerable to long hauler syndrome? It's a question from Kim Flora.
Well, because women have better immune systems than men. That's been discussed for a long time, but there's so many factors that go into this, and that's probably one of them. I mean, it's classic. Women have lower rates. They have higher autoimmune diseases because they have a better immune system, at least somewhat. But
I think we're just more outspoken about it.
well, that too. I mean, listen. I am so thankful for all the advocacy groups that have reached out to us, who have participated with us. I don't know if it's happenstance, but yes, they all happen to be led by women, which is great. And they are so well spoken. They communicate so beautifully what the real issues are. And when I had talked to some of the subcommittees of the White House recently, and another one with the NIH and the CDC, I was sure to spread the message that long COVID individuals, they're debilitated. We need to do something in terms of benefits. They're debilitated. They're out of work. They can't get the help they need, but even if they could get the help, they can't pay for it. And that's the other part of our fight. And I've assured all these other advocacy groups that we will not stop that fight. We've tried to do things as economically as possible with our website and our treatments and our diagnostics. But at the end of the day, I think we're going to always fight for this to get covered and for this to get recognized and paid for, because they're truly suffering.
I know for me, it has been a wonderful time talking to you guys. I've learned a lot, and I am super grateful that you guys are doing all the work that you're doing. I have been reading the comments, and it's so frustrating because it's like everybody's looking for an answer and there are no answers yet. But I know that you guys are working your hardest to try and get us some answers, which there was somebody who said the next talk with the White House, bring us in, because, we will advocate for ourselves and we will help you guys fight the fight if you guys want us to. So thank you.
And I'll just sort of echo what Dr. Patterson just said, because we wouldn't be here if it weren't for the patients. We're so grateful for, initially when we were just doing the research, and, I always say this in all the webcasts, when Dr. Patterson and I were talking about this cohort of patients and starting to hear about it, initially we were thinking about 10, 15 patients, just looking at, next thing you know, we've started studying hundreds, and now over 4,000 patients have signed up, are registered to go through the whole testing. So it's been very humbling. It's, sometimes as physicians, and clinicians, we think we have all the answers and the research, but we learn a lot from the patients. And I think that's something at the end of the day with this pandemic, not just only with long COVID, but even with COVID and what everyone's going through, we can learn from the patients and listen to them. And that's the one thing for me, just being also grateful working with Dr. Patterson and IntelDX, is any patient that has ever interacted with the team will know that we're so accessible. People are calling, texting. They have our, telling Bruce, we got probably change our numbers when this is all said and done. I mean, the number of calls and text messages when we were on vacation, when we were in the hospital, but we want to be accessible. We don't want to be this hard to reach people that these, oh God, Dr. Patterson and Dr. Yo and Dr. Parikh and Chris Mehta and everyone, we're not these mythical creatures. You can reach out to us. We're happy to answer questions. We're starting to do the consultations, the telemed consultations starting Tuesday for all the patients that got their lab work. So already I think we've got about 25 patients that just signed up, and we just opened it like 2 days ago. So because we want to be accessible to people and to share some of the knowledge. And I think 50% of the battle is for the patients is not only acknowledging it, but medical professionals, doctors acknowledging it. I think once they acknowledge it, that's 50% of the game. And I mean, we get these phone calls. Yesterday, there's one of the patients we've been working with. She called me from the emergency room from a big teaching hospital, and she's like, "Can you or Dr. Patterson talk to the doctors here? Because we know we've been testing her and treating her for the last couple of months. She had a bad relapse." And she's like, can you guys talk to the doctors? I'm like, okay, you know what? Here's my cell phone. Here's Dr. Patterson's cell phone. Have the doctors call us. We're happy to talk. And so it's about the science is great, as I mentioned earlier, but it's about the human element and taking care of people. And I know sometimes, the one thing I just also want to say this about Dr. Patterson is, I know some of you guys think he's just genius researcher. He's one of the smartest people. And absolutely, he's probably the smartest person I've ever met. But here's the thing that not a lot of people know about, and I think it's important that I do mention this, is that he's one of the most kindest, nicest human beings you'll ever meet. I have not met another doctor that is more compassionate and gone out of the way to help people. I obviously cannot tell you all the stories because they are personal stories that how he's interacted and touched patients' lives. And I know there's some people on this chat stream, I see their names, and I know that they have been personally, that Dr. Patterson has just reached out to them. So I think the point is that the science is fun, the research is great, it's exciting, but it's the human element. And that's why I jumped on when this opportunity to work with Dr. Patterson and his team was because it's just taking care of people at the end of the day.
Right, and that's why we talked when Ram and I talked yesterday. So or actually on a Friday, I believe it was. We talked about we do this because we care about patients. And I think, and I do want to take a minute and thank Bubba for his time, because he doesn't. Well, his wife Stacy, is very passionate about COVID and comes on my when I do my usual Facebook Lives and ask lots of questions, which I greatly appreciate. But we do this because we care about patients. I spend a lot of my time away. Generally, I work away from home. Anywhere between 3 and 5 hours away, in various emergency departments, which I've talked about. And we enjoy doing this. We're passionate about this. We, I think, would say share a collective frustration with how COVID-19 has been treated, and the the lack of a viable, well, not necessarily viable therapeutic that's doing a ton for especially really sick patients. And so we just want people to be aware and to hear unbiased opinion about what's going on. We want people to understand when what's going on, not just hear it from the media, but hear from real doctors who are practicing medicine, who are seeing these patients, who are treating these patients. And Dr. Patterson or Dr. Yo or had to come on here tonight. I mean, they've spent, I'm sure they both have things, their families they could do on a Sunday night, and we, I greatly appreciate them for coming on here. But we're all in this together. We want to help patients, and that's why we do what we do. And so I'm very thankful to them for coming on. To Dr. Patterson for his just absolutely groundbreaking research in not only COVID-19 but in HIV. He's been very modest and not tooting his own horn about all the just absolutely remarkable things he's done. I don't think that there's probably a lot of people on here that understand that having a guest of his caliber is. I mean, he is. I mean, maybe if not the world's preeminent, certainly preeminent rare disease researcher, but if not HIV researcher, and he's a great guy. And I'm thankful for both of you for Dr. Yo. You can follow him on his YouTube channel, Yo Dr. Yo. He's been doing great work educating patients throughout the coronavirus pandemic, and it's because we care, and we care about our job or our patients, and we are passionate about our jobs, and it's a part of what we do. It's part of the Hippocratic Oath that we not only do we treat, but we educate, and that's where we are and what we want to do. And so I'm very thankful to them and to Jenny for to coming on tonight, to sharing her heartbreaking story, and just reading the comments. There's so many people, just like her. As I've talked about, at least tens of millions of people worldwide who are going through what Jenny's going through right now. And so I'm thankful to all of you for coming on tonight, and for continuing all this great work with COVID-19.
Well, thank you, John, for all your tireless work on the front lines. I mean, we wouldn't be where we are without you and without you guys. So big thanks from all of us as well. So and keep up this great webcast. I think it is all about education at the end of the day. And it's hard to get the information out there. I mean, we haven't been covered by major media. Not that we're looking for that, but I think it's important to get our message out, and we'll just keep trying to get our message out by whatever means we can, and keep making people better. And that's what we do.
Awesome. All right, guys. Well, I think that's a good place to stop. If you have specific questions for for Dr. Patterson or Dr. Yogendra, certainly feel free to drop on the page. We will see. Maybe we can have them back on again sometime, where we can update things, how they're going, talk about how, I'm sure that there will be many more patients that they're curing, and they can talk about the progress they're making with their research. Certainly sounds like we've got a very exciting paper to look forward to from Dr. Patterson coming out very soon. I will certainly be sure to share that as soon as I see it. And again, I just thank you guys so much, and you stay safe out there, and we'll continue to be well and practice the 3 W's. And again, thank you so much for your time. Yes,
Thank you, Dr. Bream.
All right, thank you.